and vaccine hesitancy and barriers to quality maternal and newborn health services. In previous positions with CDC, Dr. Dines worked on reproductive, maternal, newborn, and child health programs in low-resource settings across more than 20 countries. She has been recognized by CDC and the United States Public Health Service for her contributions to emergency response activities for the Ebola epidemic in Sierra Leone, post-earthquake Haiti, Syrian refugee crisis in Jordan, and family and unaccompanied minors crisis on the US-Mexico border. Prior to joining CDC, Dr. Dines worked as a nurse midwife on the Yale Midwifery Faculty Practice in New Haven City and on the Mayo Clinic Midwifery Practice in Rochester. She's a fellow in the American Academy of Nursing and American College of Nurse Midwives and a consulting editor for the Journal of Midwifery and Women's Health. Dr. Dines received her PhD in nursing from Emory University, Master of Public Health degree from the University of Minnesota, and Master of Science in Nursing degree from Yale University. Okay, wow. Dr. Dines, please welcome to deliver a presentation entitled Maternal Mortality and System during the COVID-19 pandemic in Asia Pacific. Please welcome Dr. Dines.
Thank you so much. And I just want to say thank you for the invitation to speak to fellow midwives. It's a real honor for me to do that. And is it best for me to share my screen?
Do you want to share your screen or already?
Yeah.
Okay, you can share if you want.
Okay. Can you see it okay?
Yeah, okay, it's good.
Okay, great. So welcome everyone, and thank you so much for that kind introduction. I'm so happy to be here. And in the UNICEF regional office in Bangkok, supporting countries, 14 different countries in the East and Pacific region for UNICEF. And today I'll give you kind of a quick overview of maternal and child health during the time of COVID, specifically in the context of Indonesia. So here's a quick outline of the presentation. I'm going to give you an overview of maternal mortality globally and across the region, then focus in on maternal health indicators in Indonesia, looking at both disparities in maternal health across the country and looking at the determinants of maternal health, so factors that improve or reduce the risk for maternal mortality. And then we'll focus lastly on COVID's influence on health services, both for maternal and child health services, and a focus on how to continue those essential services. And then I've left several resources for you. If you have access to this presentation, I've left the links in for a lot of materials that you might find useful. So we're going to start with looking at maternal mortality. So the maternal mortality ratio is the indicator we usually talk about with maternal death. That is the number of maternal deaths for every 100,000 live births. So the numerator is about mothers, but the denominator is about live births. And if you look at this globe here, the darker colors are countries where the maternal mortality ratio, or MMR, is highest. And the lighter colored countries have the lowest maternal mortality ratios. Each day, 2017 was the last time we had these statistics. Each day, about 810 women die from preventable causes related to pregnancy and childbirth. So that totals about 295,000 deaths of mothers, pregnant women, or women in the postpartum period per year. When we look between the year 2000 and 2017, the maternal mortality ratio actually decreased by 38% worldwide. So the MMR is improving over time, but we still haven't met the goals globally. Unfortunately, there's a big disparity in maternal mortality across the world. 94% of deaths occur in low and lower middle income countries. 94%. So a lot of the global strategies for reducing maternal deaths are focused on those low and lower middle income countries. And as you know, as midwives, skilled care before delivery, during, and after childbirth can help save the lives of women and newborns. So let's now zoom in to the South and Southeast Asia regions. So here, the maternal mortality ratio for Indonesia is 177. So that's the, if you look, I've circled the 100 to 299 area color. That's kind of that dark pink color. And when we compare that in the region, there's many countries that are about the same maternal mortality ratio. So you can see all the way from Timor-Leste to Myanmar, Nepal, Solomon Islands, all of these countries you see here are in that same general category for maternal mortality ratio. There are some categories in the lighter pink color. Here you can see Malaysia, Thailand, Sri Lanka, China, among others. And then finally, there are a few countries, less than 20 maternal mortality ratio: Japan, South Korea, Australia, and New Zealand. So even within the region of South and Southeast Asia, there's quite a disparity in maternal deaths by country. So now let's focus in on maternal health in Indonesia. So here you can see the maternal mortality ratio from the year 2000 all the way through to the year 2017. And the really good news is that the maternal mortality ratio in Indonesia is decreasing over time, from 272 in the year 2000 to 177 in 2017. But what we have seen in Indonesia is some disparities by different characteristics of women. So let's focus in on maternal health by education level. So 99% of mothers with a higher education level reported having a skilled birth attendant. 70% of mothers with a primary education had a skilled birth attendant. And now let's compare that with mothers with reported no education. So only 32% of babies born to mothers with no education had a skilled birth attendant. So here you can see a significant disparity in skilled birth attendants between mothers with higher education at 97% and mothers with no education at 32%. Now we can look at the disparities by geographic area. 88% of mothers in the Java Bali region reported having a skilled birth attendant, but only 67% of mothers in the outer Java Bali 2 region had a skilled birth attendant. So here you can see geographically those more difficult areas to reach, more rural areas have lower coverage of skilled birth attendants. And then looking by wealth of the mother. 99% of deliveries to the richest households had a skilled birth attendant. And only 58% of deliveries in the poorest households had a skilled birth attendant. So you can see a significant disparity by household wealth. And I wanted to share the findings from a study that was conducted. The study was published in 2019, and they looked at a large number of deliveries in Indonesia and identified characteristics of the health facility or other characteristics that might help to determine which women are at risk for a maternal death. What they found was health service access and characteristics accounted for 23% of the difference in mortality between high-performing provinces and provinces who were low-performing. So I'll give you more specific information. They found 3 factors that were the most important. They said the number of doctors working at a health center accounted for more than 8% of the difference between high and low performing provinces. The number of doctors living in the village accounted for about 7% of the difference in mortality between high and low provinces. And then the distance from the woman's home to the nearest hospital accounted for about 6% of the difference between high and low performing provinces. So those factors help to identify areas where we can actually make efforts to focus in on those areas to improve the number of doctors and also facilities and distance to hospital. So what they determined ultimately with this study was that if women had the same level of access to doctors and hospitals in the outer islands of Indonesia compared to the higher performing areas, they predict that they would save 44 deaths for every 100,000 pregnancies. So if your maternal mortality ratio is 177, they can expect quite a significant reduction if access to services was improved. So now let's talk about COVID-19's influence on health services. So the government of Indonesia and UNICEF partnered together to do a rapid assessment of maternal and child health services. And this data was collected in April and May of this year. This is going to show us the proportion of health facilities and community level suspensions that had occurred in the week before the survey. So they asked health facilities, were your services suspended in the last week? They found that for the puskesmas, about 7% reported having suspended health services. For home visits, a little bit less than half of home visits had been suspended. And then in the Posyandu health posts, almost 80% of health facilities reported they had suspended health services in the last week. So here you can see the significant impact of COVID, at least in April and May of 2020, happened at the health post and home visit level. Now we're going to look at the proportion of facilities the type of health service that had been suspended at the Posyandu level in the week before the survey occurred. And they asked about growth monitoring and development monitoring for infants and children. And they found that more than 80% of these services had been suspended at the Posyandu level. They also asked about immunization, and more than half of immunization services had been suspended. And then finally, vitamin A and antenatal care for pregnant women was a little bit less than half of Posyandu level had suspended those services. So here we can see the significant impact in terms of access to maternal and child health services during that time of the pandemic. And then finally, let's look at some of the reasons that were reported for services being suspended. 64% of the facility said it was due to community concerns about COVID. 43% said it was due to concerns on the part of healthcare workers. A small percentage, 3%, reported it was due to health worker illness. And then almost half of the facilities reported suspension due to the guidelines related to physical distancing. So those were the most common reasons reported for facilities suspending those services. And now let's take a look at immunization services, which is another really important intervention for maternal and child health. So they asked, has there been any disruption to the provision of immunization services? And more than 80% of health facilities said yes, immunization services were disrupted. They asked at which level was immunization service interrupted. And what we see here is that about 9% of the Puskesmas level facilities reported immunization interruption. More than 1/3 of Posyandus had immunization service interrupted, and more than half of the facilities reported both at the Puskesmas and the Posyandu level had immunization service interruption. And then they asked, for those who said there was interruption, to what extent were services interrupted? And actually the findings report here that about 2/3 of the Puskesmas and the Posyandus had partial stopped those immunization services, and about 1/3 of both Puskesmas and Posyandus completely stopped immunization services during that time. So as a result of those findings, the government and UNICEF came up with some recommendations for ensuring that essential health services for mothers and children would be sustained. I'm not going to read through each of these, but I just wanted it to be available to you for your own knowledge. But there are specific recommendations related to antenatal care and to delivery services, to postnatal care and essential newborn care, and to under 5 care and family planning. And I hope that you'll have access to the presentation because I've included the links to these resources. And finally, some more resources that you can use, including the links. These were the 2 reports that came out of that rapid health assessment that I described the findings for related to immunization services and related to care of mothers and children. There are additional resources here about childbirth and human rights during the time of COVID. This resource on the right is called Every Mother Counts, and it has a lot of helpful resources both for mothers and families as well as for healthcare providers. There are links here to research articles about guidelines for caring for women during pregnancy and their babies related to COVID, and the presentation and outcomes for pregnant women and neonates who experience COVID infection. And then finally, there's many resources that the Indonesian government has put together for important messaging about COVID and care of mothers and children. And I just want to say a quick acknowledgement to the Indonesia country office for UNICEF, the regional UNICEF office, the Indonesia Ministry of Health for all of the work they've been doing on COVID. And also, I want to say directly to healthcare workers and midwives out there, thank you for all of the work you're doing. Thank you so much.
All right, thank you very much, Michelle, for the interesting presentation. And yeah, we got some many information and data related to maternal health in Indonesia from Michelle. Thank you very much. And Michelle showed the data about the maternal mortality. It was higher than I told you. It was 177, right, in 2017. Okay.
You know, and just one thing about that is some people will talk about a maternal mortality rate, which will be a different number using, it's a different calculation. So you may have been referring to that versus the maternal mortality ratio.
Okay. So,
yeah.
Yeah, thank you. And yeah, I mean, from the Michelle slides that we can understand how the disparities still exist in Indonesia, right? Especially in the rural and urban areas. And there is a very interesting comment. If some level of access to doctors and hospitals was provided to outer islands, it is predicted 44 deaths will be averted forever from 100 and 100,000, right? So, I mean, it's a challenge for us because, I mean, we cannot deny that geography, for example, is still a challenge for Indonesia, or even the transportation and many other factors. And from three speakers, we can conclude that COVID-19, yes, really affect maternal health services, not only in Indonesia, I suppose. You can see from the presentation from Deborah or Louis and Michelle, you know, in every country's COVID-19 really affects almost everything in life, including maternal health. All right, thank you very much, Michelle, for the presentation.
Thank you.
Please stay with us. And now I will welcome our fourth speaker, the one and only man, I suppose. Yeah, he is not a midwife, but obstetrician and gynecologist, because in Indonesia, midwife must be a woman, right? So yeah, we are inviting him because we would like to get insights from obstetrician, who is midwife's closest partner, obviously. His name is Dr. Sutrisno, SPOG consultant. He is currently the president of Indonesian Medical Association, is Java Regional, and he is also the president of Indonesian Association for Obstetrician and Gynecologists, Malang region, and also a lecturer at Master of Midwifery Program, Universitas Brawijaya. He has long experience in obstetrician and gynecologist field. He is also active in conducting research, doing publication, and writing articles and books. Yeah, and I know that he also loves arts, music, and recently cooking, right? Very interesting. All right. Dr. Sustrisno, please welcome to the presentation. He will cover the topic of maternal health challenges and system in Indonesia during the adapting to new habits era.
Okay.
Maybe he will also talk a little bit about maternal health situation in East Java.
Java, yes. Thank you. Thank you very much. Thank you very much, Mercy. Can you see my PowerPoint?
Not yet. Still, your Explorer. Can you
No?
open your PowerPoint?
No? Can you see?
Not yet. Not yet.
Not yet. Not yet.
This
Oh,
one is
stop share.
Finder window.
No? I will start again. Share,
Okay.
share
Can
screen,
you
right?
start again?
Share screen here. Now I will point it to my PowerPoint. Can you see that?
Yes. Can you start slideshow?
Let's slow. Slide. So that's right. Okay.
Okay.
You
can
Thank you
start.
very much. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Thank you, Deb. Thank you, Louis. Thank you, myself. Also, Bu Emi. I think good evening for all except Louis. Good morning, I think. Alhamdulillah. Dari Alman. Thank you, Mercy and Josefa. Alhamdulillah. Thank you, Dr. Yahya, Dr. Bambang, our friend here. It's very nice. And now at my home, there is a very heavy rain. So the situation is colder now. How about you, Mercy? Is there rain in your home or in the faculty?
We live in the same place, right?
Thank you very much. Thank you for the commentator for inviting me to join to talk in the seminar. And I just mentioned to Michelle and Louis, also Deb, this is not the last meeting, but I hope this is a start for continue projects, right? Very nice hearing and seeing the PowerPoint and data from Deb, from Louis, from Michelle, and from UNICEF. I think everybody in Indonesia, when see the number, the data that been presented by Michelle, very happy because maternal mortality looks lower than the formal report that we already heard every day. Because Indonesia, I think, is very big, very huge maternal mortality. This is a huge problem that cannot be solved until now. This is my lovely Brawijaya University, lovely medicine faculty, lovely hospital, Southfull Under General Hospital, Type A hospital, have a 1,000 bed capacity. It's very nice. Thank you. This is my objective of my talk in this evening about one understanding about the current situation in COVID-19 in East Java. And I will talk specifically in East Java, and second understanding about the impact on the maternal mortality in East Java also. We can compare with myself and understanding some alternative ways. Maybe we can get it from this such situation. This is United Nations Secretary General Antonio Guterres has rightly called COVID-19 crisis the greatest test since World War II. To pass it, leader everywhere must recognize. While the pandemic affect everyone, those who were already marginalized, including women, ethnic minority, and the poor, we should take care and many attention. So this is also in Indonesia and Java. We can see from this picture that the number of positive increase day by day. Today, maybe over than 30.6 million in the world and more 650,000 cases reported by WHO. It's very, very huge, something very hard for us. Also, in the Southeast region, also very, very hard bad in COVID-19. I think we can see and from this table that the Southeast area is number 2 after United States of America. Also, we are in Indonesia. Almost part of the province in Indonesia have a the red area, and we can see here that day by day the number increased significantly from here to Indonesia, and daily cumulative number of cases reported in Indonesia until 23 September was this one exceed 200, more than 200 positive cases in Indonesia. This is something that makes us very sad. Also, we are in the East Java. Time by time, the condition to be worse. You can see here East Java, the total number is number 2 after Jakarta. But the death rate East Java is number 3 after Jakarta, Kalimantan, and East Java. But the absolute number is Java is number 1, absolute number. But the rate is number 3. Why? Because the tracing and testing not so good. In Jakarta, testing and tracing is better than the other provinces. But East Java testing and tracing not so good like Jakarta. That's why absolute number of death number 1, but the rate of the death is number 3. This is hospital. Hospital is something that's very important. Hospital is hope for everybody, for many sick people. Hospital in such situation is like joining running of competition. First sprint, being shocked with the judicious human resources, scale, equipment, system, and not being well prepared. This is sprint. That's why many doctors in East Java, nurse, midwife, all kind of human resources in the hospital being infected and increased number day by day. In Indonesia, more than 115 doctors die because of COVID-19. Also, nurse and midwife getting such misery. Having similar condition, in Java almost 30 doctors die related to COVID-19 condition. This is very hard for me. After sprint, the hospital should marathon. This conflict is still question where will be ended. Maybe 1 year, maybe 2 years. WHO mentioned maybe the impact almost 1 decade, almost 10 years. This is very hard. It means that health worker and hospital should prepare better against SARS-CoV-2 virus for long time. This is long competition. This is the marathon. That's why for hospital, this COVID-19 problem looks like run competition. Sprint continues to marathon. Very hard. How about in the East Java? We can see here in the East Java, totally about 385 hospitals. Most of them are Class C and Class D, and only 1% of them Class A. All of these hospitals are mixed hospitals. What is the mixed hospital? Mixed hospital is the hospital that treat infection and non-infection. If COVID-19 some kind of new, very easy to spread, and getting coming to hospital, having great potential to be transmit to the others. That's why mixed hospital for us now quite dangerous if we treat COVID-19 without any changing. Those we just always give some attention to the management of the hospital. Please to change the system. Please change the hardware. Please change the human resources scale. and always update new information related with COVID-19. The current situation now, you can see from this slide, that this is the total hospital. To be referral hospital for COVID-19 is 127. But not all these hospitals ready to treat the COVID-19. Not all having negative bathroom, negative operating theater, and negative isolating room. That's why it is take long time to make this 127 hospital to be ready as the good referral system for this one. So the great burden on the shoulders of the type A hospital. And now we can see here that based on the daily report, the intensive care unit, high care unit, ward, emergency unit, full with patients that come from all parts of the eastern Java. This is a potential infection source for the health worker, for the hospital staff, for the patient, for the family, because the COVID positive still treat in emergency, still treat and still not getting the ICU for long time. Also, there is the patient positive COVID-19 that start in the clinic or small hospital. This is very potential. It will spread infection to the healthy people around this little hospital. How about maternal mortality? We can see here maternal mortality as something a variable that's very important to determine the human development index in one country. I think UNICEF understands this very much, and lower maternal mortality related with the better quality of the human development index. And also, Michelle also talked to us, and I maybe give such a different data. The Indonesia nowadays, the maternal mortality is about 359 per 1,000 live birth. This is the data that we hear every day when we talk about maternal mortality. So we can predict that every year there is 14,000 pregnant women die in Indonesia related to the pregnancy. I will show about in the East Java province. This is data. We can see here from 214 until 219, no changing in maternal the die of maternal die of mother from the pregnancy related disease. Always more than 500. This is the absolute number. This absolute number, not rate. This absolute number. So in the 2019, 520 mother die related pregnancy. I will show this data here next. This is a report from the Dinas Kesehatan about maternal mortality that we compare with the same period in the last year. We can see here, there is any differences between between year now and before. We can see there is the 10 district that the maternal death increased significantly in the period of the COVID era, and the rest still looks like before. We can see also etiology of maternal death. We can see COVID-19. There is 3.4% of the maternal death identified as the COVID-19 as the basic etiology or the death of the maternal. This is the first time in our human civilization that there is disease, new disease, as etiology of the maternal mortality. The name is COVID-19. About the bleeding, about the preeclampsia, about the infection, this is always we found every day. But the COVID-19, this is the first time during our human civilization to be the disease that can cause as the basic etiology of the maternal death. You can see the variation in each district. The highest number of maternal mortality in Jember district, and the secondly in Bojonegoro. This pattern is looks like before. In the 2019, the pattern like this one. Jember is the highest, and secondly, Bojonegoro and Surabaya. This is something, this is questions that is meant, looks like puzzle that we should looking for the solution. What is the basic etiology? Why the region that have position number one, number two, and number three not changing year by year? From the slide, we can conclude that there is possibility about 7% for the pregnancy woman to be die if diagnosed as COVID-19. So this is something that we should take care, take any attention if we face the woman, pregnancy woman with the COVID-19. This is some distribution of the ages, most of them in on the 26 to 30 years. So this is very young woman. Sometimes we are very sad by this one getting died in the young period of her life. And this is the case of positive. We can see almost all part of the district in East Java. There's the positive of COVID-19 in pregnant woman. From this picture, we can see that postpartum period is something that's very critical. Why? Because most of the dying happen in the postpartum period. That's why after being delivered, please don't lose in monitoring. So tight in monitoring. Take so hard attention because why? The data mentioned that most of the maternal die in the period of postpartum. How about the place? This is something that we can take some conclusion that place of it generally in hospital. Why? Because if there is something wrong with the delivery, with the labor, the midwife or small hospital directly sent to the hospital. That's why in such situation, most of the death happen in the hospital. Secondly, the private hospital also, um, private hospital, if there is something wrong with the maternal, they directly sent to the general hospital. But we can take some point in Bojonegoro that there is 5 pregnant women die at home. Also in Pamekasan and Situbondo, 1 pregnant woman die at home. This is something that is a point, a point why in this nowadays there is the woman delivery at home. Maybe, maybe this assumption, maybe very scared to come to the health facility, scared come to Puskesmas, scared to the little hospital because of COVID-19. So this is the indirect impact of the COVID-19 to pregnancy women. About the current situation, something that's very difficult, but there is the data from a big hospital, a Saiful Anwar Hospital, type A hospital. This is a second type A hospital in East Java. I can show the data to you that start from May to August, the number of the COVID-19 pregnancy increase. Most of them, the mode of delivery by cesarean section, and most of them had been delivered referral by OBGYN, by midwife, also the private hospital, because of they think the Saiful Anwar is big hospital. This is good place for to be referred to there, and we are take care very much for the pregnant woman. So why all the COVID-19 maybe will be sent to the general hospital. Also in Dr. Sutomo General Hospital looks like this one. And we can take conclusion that time by time, month by month, I think the number of the pregnancy women that positive with the COVID-19 will increase. So that's why we should adjust the system in our hospital. We are OBGYN, we are midwife, should more familiar with COVID-19. So we don't scare anymore with such disease, and we will have good technique, good skill, and proper time to make a decision how to help, how to deliver, how to refer. From this data, the good management, the good decision, the good solution to woman with the positive COVID-19, something to be mandatory, something that's very important. If we don't have any solution, the maternal mortality will increase significantly. Also about the contraception. Contraception will prevent some women to be pregnant. So the access of contraception decrease by the time of COVID-19 pandemic. So we can imagine if the access of contraception will decrease, maybe the pregnancy will increase. This woman unintended to be pregnancy, this woman have handicap to access the facilities, and the trouble, the morbidity will increase. The diagnosis in the early warning system is not so good. That's why the woman will face with great burden and the maternal mortality and morbidity. So we can imagine we should, for the government in all level, should take main attention how to looking for good system, good diagnostic and early warning system, good referral system, good facility to manage the pregnancy woman with COVID-19. You can see here, not only maternal death, maybe neonatal death, stillbirth also have the similar situation. That's why we should we should we should train our midwife, our OBGYN to make more familiar with the COVID-19. They can manage COVID-19 very well, so we can depress about the possibility of the maternal mortality to be worsening. And the last, I think the four pillar of safe motherhood not change, but need adaptation. Adaptation to era of COVID pandemic in service and primary level, service in secondary level, also service and tertiary level. Also next, if they succeed, adaptation in the new era after the COVID-19 pandemic. So don't forget about telemedicine. I think everybody have a handphone. They are very familiar with handphone. When they stay in the rural area, everybody not staying with the handphone, very familiar. So telemedicine, telehealth, something that mandatory, and we can take this one to be positive point, to give service, or to give some advice, to give consultation without physical contact. And as my conclusion, I give some point during pandemic COVID-19, there is increasing number of maternal death in 10 districts in East Java province. And compared with the year before, February or January to June, there is a number insignificant. And basic etiology maternal death still like before, but there is COVID-19 as the etiology of the death of the mother in East Java, and most of basic etiology maybe is indirect impact of COVID-19 for maternal. Thank you very much. Thank you for kind. I back to Merki.
Okay, thank you very much, Dr. Sutrisno, SPOG consultant, for their presentation. I think he has already given us the conclusion of his presentation. Yes, the pattern, the trend of maternal mortality in East Java particularly remained the same since 2014. Also, during the pandemic, there was an increase of maternal mortality in certain districts in East Java. And yeah, it has been solved. It's still a big question for us, also the challenge for all of us here. And in terms of home birth, he showed us the data that 5 pregnant women died at home. And there was a question from him that how come women nowadays still give birth at home? Maybe it's a question for Indonesia setting, because in developed countries such as Australia, UK, also maybe Netherlands, home birth is actually safe as hospital birth. But in Indonesia, because we have a very different setting with those developed countries, that's why home could be not the best place for give birth. Yeah, this is also very interesting. Maybe in the future we can also discuss further on this. Okay, thank you for your presentation. Please stay with us. Last but not least, ladies and gentlemen, let's welcome Ibu Dr. Emi Nurjasmi MKes, the President of Indonesian Midwives Association, aka the mother of Indonesian Midwives. We are very honored to have Ibu Emi here. Dr. Emi Nurjasmi MKes currently works at Health Polytechnic Jakarta. She is also Vice President of Women's Health Education Foundation, the expert team in social and family health at Indonesian Women's Congress, assessor for Board of National Accreditation for Higher Education, one of the founders of Institution of Independent Accreditation for Indonesian Health Higher Education, Vice President of Midwives Alliance of Asia, and board member ICM representative Asia Pacific region. And yeah, she has also experience in midwifery field, and she has been a midwife since 1976. Mashallah, it's been a long time, right? So yeah, Bu Emi, okay, we have listened. She will yes, we have listened to maternal health and system in the 4 different settings from the previous speakers. So Ibu Emi will deliver a presentation entitled, "What Should Indonesian Midwives Do?" This is gonna be very interesting, I suppose. Okay, so please welcome Ibu Dr. Emi Nurjasmi MKes.
Okay, thank you very much, Mbak Maggie, for introducing myself. And good afternoon, everybody. First of all, I would like to thank to Brawijaya University what was invite me to also participate in this webinar. And I would like to share some information, but there are many information that already shared by a previous speaker. Even though from the UNICEF, also she has the very comprehensive data, and thank you for this. What is the name? Ibu Michelle. Yeah, thank you, Ibu Michelle, that we can see the data of maternal and neonatal health in Indonesia comprehensively. And also that what Dr. Sutrisno said, I think that we see the data. Let's say we are talking about the maternal mortality rate. This is amazing data that's it's not as what data we know in our country. It is the information, I think it is the very important. Let's see, I would like to share information, or maybe partially, and maybe just the generally of the maternal health adapting to new habits in COVID-19 pandemic in Indonesia. And we are talking specifically, what should Indonesian midwife do? It related what the organizer asking me to talk with this topic. Okay, let me see the Indonesian geographically, then I'm sure all of you already recognize this, but we have to see and we have to understand also the situation between countries is different. We have many differences. We have many problem, and maybe the problem also we have a specific problem. In Indonesia, the big problem I think that is in our country, that we have so many islands in our country. It means that our transportation geographically, how to achieve the health facilities, I think that would be a big problem also for us in Indonesia. This is just overview of the Indonesian here. And also by the population, now almost 270 million population, with more than 17,000 islands. And we have more than 82,000 villages. I would like to I would like to share or overview about the midwife and midwifery in Indonesia first. That the legal basis of midwifery profession in Indonesia, that we have the some regulation who are regulate midwife as a professional health provider in Indonesia. And fortunately, from some regulation, that there is the regulation specifically regulate midwife. Let's say we have the health workforce law, also regulate for all health professionals in Indonesia. Midwifery law specific, of course, regulate our profession. Fortunately, we have midwifery law and also some health ministerial decree. It is the legal basis. Beside this legal basis, also so many regulation also related, also in line with the scope of work, and also the midwife as a profession in the country. I would like to share shortly. Midwifery services is a form of professional service that is an integral part of the healthcare system, provided by midwife, could be independently, collaboratively, and or referred. An independent practice midwife is a healthcare facility organized by midwife with professional education graduates to provide direct services to clients. It means who are open their own clinic, my colleagues midwife, they conducted the independent practice midwife in their clinic is account as a health facilities in Indonesia. I would like to also give you the overview about the midwifery education. Regulated by our law, we have the vocational, scientific, or academic, and also professional. I don't want to explain more about this, just overview. And for the vocational, we have diplomacy. Scientific, we conducted bachelor science, magister science, and also we prepare in our regulation for doctorate program, but not yet run until now, but we can do it. Maybe for the next future, we have to also to conduct, to open, to build also for this program. And also we have the professional program, let's say looking like internship after bachelor of science or advanced of undergraduates. And also we have the system, all of the students at the end of the education, they have to follow the national competencies assessment. This is the registration process. Every midwife who will carry out midwifery practice must have a registration certificate. Registration certificate is given by the council to the midwife who meets the requirement. Registration certificate valid for 5 years and can be re-registered after fulfilling the requirements. Fulfilling sufficient in midwifery practical activities, education or training, and or other scientific activities, we say continuing professional development, community services, professional services, and professional development by research and some also for publication. The licensing, of course, midwife who will practice in midwifery must have a license. Wherever they would like to practice, they have to have the license. Practical licensing is provided by the district health officer. To get the license, must have the registration certificate and practical site or facilities. License also will valid for 5 years in line with the registration certificate. This is the scope of work of a midwife in Indonesia. We can give serve for the maternal health, child health services, women reproductive health services, and family planning. Also, we can get the delegation task from the others partners, let's say from the OB/GYN, from a pediatrician. And also we can take the delegation from the government with the specific condition, with the specific limitation. Let's say in the rural area, there are no other health provided there. The government can give the delegation to the midwife. The task of the midwife can be carried out independently or collaborative or collaboration. Implementation of tasks is carried out in a responsible and accountable manner. Midwife in administering midwifery practices must be in accordance with their competencies and authorities, and also in carrying out the provision of maternal health services, child health services, and reproductive health services for women, and family planning can be done with community midwifery services approach. As you know, 70% our midwife, they are working in the first level facility. We call the first level facility close to the community. And this scope of midwifery practice in continuity of care. We know midwife is a care provider with a strategic and unique role as a partner for a women and society, especially in carrying out their reproductive health cycle through holistic and continuum of care with the maternity respectful care approach. What are the activities, what are the practice we can do in our practice, in our services, that we starting from the health promotion, disease prevention, care for pregnancy and pregnant women, conduct or facilitate for normal delivery, postpartum care, care for babies, toddler, women's reproductive health and family planning, screening for complication, carry out emergency care, and referring high-risk cases, and mobilizing community participation and empowering women and families, because more than 70 midwives, they are stay with community. In carrying out their duties in providing maternal health services, this is for the maternal health before pregnancy, that what I mentioned before, I don't want to repeat it again. And also in carried out of the task of providing child health services to newborn, infant, toddlers, provide immunization according to government program, and monitoring growth and development of infant, toddlers, and preschool children, early detection and emergency care in newborn, and followed by refer. Also for family planning, we can give the communication, information, education, and also we can provide family planning services, including also to for the IUD insertion and also implant insertion with the certification. Okay, now let's say what is the challenges now in the COVID era, in the new habits, the challenging facing women. There is still a lot of hot information related to COVID. We hear every day. There are so many information that are confused, and there are still diverse public understanding about COVID-19. The level of anxiety for women is quite high, including for pregnant women. Without realizing it, many as usual, risk and transmitting of pregnant women. Also, community compliance is still low, fear of seeking health services. And what women voice, what patient voice in these challenges? Do pregnant women have high risk of disease and death due to the COVID-19? And can the coronavirus be transmitted from mother to the fetus? And can contracting the coronavirus create a greater risk of miscarriage or preterm labor? I think there is the many questioning in women's head. Yeah, they are feeling these many questions. The role of independent practicing midwife in pandemic era, we socialize and provide education to the community related to health problems during the COVID pandemic by optimizing electronic media, because we have some limitation to see, to interact face-to-face or offline. Continue to provide healthcare services by using PPA according to standard, and implementing health protocols and patient management by tele-registration and triage. Collaborate and coordinate with other professionals or other health facilities, such as public health center, hospitals, or etc. And prepare independent practicing midwife facilities according to health protocols during the pandemic COVID. This is the maternal and child health services in pandemic. This is developed by Ministry of Health, and also together invite us as an association, also OBGYN, also pediatrician, and some profession related with the maternal and service and neonatal services. For the antenatal care, we have the change how to give the antenatal care in this pandemic era. First, antenatal care, make an appointment with the midwife or with the doctor. Postpone the next pregnancy checkup. Check up once with the doctor on trimester 1. And perform antenatal care in the trimester 3, 1 month before delivery. Check advance of the maternal and child health with using the handbook, and also medium for the information, education, and counseling. Use the communication media for consultation. Pregnant women, families, and carers play an active role in monitoring danger signs of pregnancy, or make an appointment if they are compliant that require examination, or also handling for preparation for complication. And also that's guided with line postpone classes for pregnant women. It means this we will see in the next slide. We have the change, the timing of the antenatal care, the number of the antenatal care. And also intranatal care, I think that's a referral for plain delivery for pregnant women. That's why we have to screening early or early detection and go to the for pregnant women at risk, immediately go to the health facility if there are signs of labor. This is the early breastfeeding. Combined care is not recommended for the who are suspect in COVID. And also we have to use the PPA properly based on the standard. Also postnatal care, I think that there are also some changing, because in postnatal care also, if there are no complaint, if there are no problem, they can stay in the home. And if they would like to interact with the midwife, we will use the consultation online consultation. Also for breastfeeding mother, I think also it's quite similar. Infant, also for the what we call the posyandu health integrated post in the villages, in some area closed, but in some zone is still open, but they have to follow the health protocol. This is the early warning system that we present and also we socialize to our member, because all our client, all pregnant women, let's say, they come to midwife, they cannot see the result of the rapid test. That's why this is the instrument really usable for the midwife. They can identify this. If they meet the score equal or more than 10, they have to refer. This we socialize, we present to our member. And there is the changing of the midwifery services in the COVID area. The principle of midwifery services during this pandemic COVID, we divided in three kind of services: pra-services or pre-services, during services, and after services. Pre-services, that consultation will be done by online, and when they would like to come to midwife, they have to online registration first. In this online communication, midwife should ask the comprehensive information about this pregnant woman. And also in the during services, I think that we have to use the standard, whatever the activities, let's say for the childbirth, for the antenatal or postnatal, we have to use. But the important thing that we have also to be careful, to aware about PPA as well as standard. After services also, that we can do follow-up care by the online. And one again, if they have a problem, they can come to clinic or to hospital or to public health center, but before they come, they have to register through online registration. And also the MCH handbook, it is very, very usable now in this situation, because our client, our mother, they can learn, they can read in their home. And also sometimes if they are not understand, they can contact midwife, we can discuss based on online. This is the take home message, where we say the continuity of midwifery care in optimizing. Also we starting from the antenatal care. We have some standard. Women empower and use the MCH book also. You can, I don't want to read it one by one. Intranatal care, also based on the standard. Postnatal care, infant and child health care here, and also women reproductive health care. We have the standard for all kind of the services of the care. And I would like to also make it you can empathy. the antenatal care, childbirth assistance, early breastfeeding, and immunization, we are in a midwife association. We conducted a survey by using the Google form, and it is from January, February until April that we see the graphic is going down for the first antenatal care, and also for the fourth antenatal care, they're going down, and for the delivery, quite this is the increase small number. It means maybe our client, they are very wondering to go to the hospital, to go to the public health center. Some of them, they are going to private clinic or independent practicing midwife. Also, this is the early breastfeeding. This is the immunization. That immunization really, we are wondering about this data, because the data is really going down approximately maybe almost 25% in this 4 months. In the first quarterly, we in IMA, we are doing we did the survey. Also for family planning, that's IUD. It is also in each month, January, February, March, and April. That's also going down, the graphic. Implant also, let's say another one, injectable and pill, yeah, quite also decrease. This is pill. This is the situation in the first quarterly 2020. Now, there is that I took this slide from Ministry of Health. That achievement of maternal child health services 3 monthly, in the second 3 monthly at 2019, we compare to 2020. Let's see, the blue one is 2019, this one in 2020. For the antenatal care, 4 visit increase, and postnatal care also increase, and neonatal care also increase. Immunization is decrease. It's decrease. The number, the graphic we can see, and it is the fortunately we can see this data. This is amazing data for the exclusive breastfeeding, increasing exclusive breastfeeding in the second 3 monthly 2020. In this data, this graphic, this slide that I took from the Ministry of Health slide. Okay, here is the take-home message. The spread of COVID-19 cases is very fast, both in the world and in Indonesia. COVID-19 knows no boundaries, can affect anyone without exception, including pregnant women and children. During the COVID-19 pandemic and facing the new habits, health services must continue to run optimally, safe for patients, and of course, safe for midwife. Various adjustments to health protocols are needed. Also in private independent midwife, they clinic, they have to fulfill the facilities. Midwife and patient must adapt, take advantage of IT, online education. Mostly we will do by online communication. This is the last one. What the IMA's in commitment to supporting MNH and family services in the new era. We perform consolidation, communication, and coordination of all board teams from national, provinces, district to virtual meeting. We collect the data, we collect the information, and also seek assistance from various stakeholders to obtain support and assistance for EB members, specifically for PPA. And we already get some supporting, very much supporting from our stakeholder, even though from the Ministry of Health, the Family Planning Board, and other non-government organizations. improving the quality of midwife through webinar, online module and training or continuing professional development daily, every day. We conduct a webinar. And distributing also MGS and family planning services guideline in the COVID pandemic situation and new normal from Ministry of Health, OBGYN Association, Pediatric Association, and Indonesian Midwife Association. And also we conduct coaching, facilitative supervision, and we develop also manual and digital instrument for we are a member who are joined for our standardization program we call the Bidan Delimas program. Yeah, this is the example. We can see the innovation in adaptation in pandemic era in our member clinic, in our college. This is the before pandemic, before they use the register or online registration. The patient come together, they meet there, and also they bring their child there, but not now. They have to registration by online first before they come, and the midwife can manage the time. It means the patient they will not come together with others patients. And also this one, the last adaptation in pandemic era, we use the virtual consultation with any application. We can also discussion for the MGH handbook, and also we can give the education. We can also video call with our member, with our patient. I think this already done in some of our colleagues in independent practicing midwife. This is the last, of course, that we have to be careful, stay at home. And also this from the Family Planning, National Board of Family Planning, they just launching, what the application we call the Click KB, Family Planning Click. This application can be used by midwife. They can communicate with other midwife, and they can communicate with their patient. I think this information I can share. Maybe in the discussion we can discuss for more information if you need other information. Thank you so much. There is no, I don't want to share this one. Yeah, thank you.
All right. Thank you, Ibu Emi, for the presentation. I think it's very clear that, yeah, COVID-19 remains a challenge in Indonesia. And then there have been some, strategies that have been implemented to reduce the, the case of the impact of COVID-19 pandemic. Okay. Yeah, thank you very much for all presenters for their informative and interesting talk. Very well, ladies and gentlemen, before we come to question and answer session, I'd like to please our guest from Indonesian Midwifery Education Association and Indonesian Midwives Association to greet our speakers. Halo, mungkin ada yang dari IPKIN, Buyung. Maybe there's something that you would like to, maybe you want to say hello to the speakers. Apakah ada di sini dari perwakilan IPKIN? Okay, maybe we can do later. Now we are moving on to the Q&A session. I have some question on me. Okay, the first question is for Luis. It's from Indira. So how is the screening examination that health provider in the UK do when there is a pregnant woman coming to the hospital for delivering their babies in this COVID-19 pandemic? do they have to, do the PCR or swab test?
Hi, yes, most all trusts now within the UK are testing women on admission to hospital. Very often we might get that test back within 24 hours, and obviously practicing with full PPE, but it is fully been tested, and we're actually seeing quite a very small number of pregnant women coming into the hospital now with the positive infection. So so in our maternity services, they are thinking on, they've started to reduce the full level of PPE down to hopefully help with the support of women in labour.
So how if in the case where there is emergency labor, when you're not ready, you don't know about the records of the women, and then should you still do the PCR test?
We still do that test, and obviously we don't know, or if women are coming in with symptoms, then they're treated as COVID positive until we get that test back to say they're negative. So there will be precautions put in place, especially if women are coming in with symptoms.
Okay, thank you. Tetap dilakukan ya, meskipun apapun itu kondisinya tetap dilaksanakan gitu. Okay, and the next question for Luis, is it possible to do continuity of care on mothers during this pandemic, particularly in the district of which the case of COVID-19 is very high?
Yes, we do work on continuity models, and it's something that we've been trying to introduce more widely since 2016, when a document called Better Births was published in the UK. And there are a lot of continuity teams that are providing that care for women, and where possible, that is continuing. The barriers to that happening are usually sickness, midwives who may be needing to self-isolate because of contact with other people who have been positive. So that's been the only challenge and barrier to the continuity, but it's still trying to be maintained to give women that support that they need.
Okay, thank you. So masih ya tetap dilanjutkan, kecuali memang challenge-nya itu kalau memang positif kan ibunya harus isolasi mandiri. Nah itu katanya yang agak menjadi challenge. Okay, thank you, Luis. We are moving to the next question for Michelle. Is COVID-19 transmitted to fetus during pregnancy or maybe during delivery, perhaps from amniotic fluid? Something like that.
So there's very little evidence that the fetus will get SARS-CoV-2 infection just intrauterine from the placenta or the amniotic fluid. There are a few cases that have showed positive newborns tested soon after delivery that suggests the possibility, a small possibility, of transmission during the process of delivery. And that they don't know whether that's through exposure to the mother's fluids or tissue during delivery, blood, or having exposure to the air, at the time of delivery. But overall, the risk is very, very small that a newborn would get COVID-19 during the process of delivery. And the WHO and other global and national organizations strongly recommend continued breastfeeding or feeding of breast milk, even if the mother is COVID positive, but to take precautions, including mothers wearing the mask, good hand washing during breastfeeding. So that's the probably most important lesson is we want to continue to encourage breastfeeding even when the mother tests positive, and encourage good hand hygiene and use of mask during the feeding time. That's the most likely way a baby can get infected, is just coming into contact with the mother, coughing or sneezing when they're holding the baby. And but the risk of getting COVID through breast milk has not been established.
Okay.
Okay.
Ya, thank you. Jadi memang evidence-nya masih terbatas, hanya saja memang menunjukkan bahwa risiko untuk apa ya terkena COVID itu ke bayi atau itu sangat kecil gitu untuk risikonya. Bahkan bila ibu masa menyusui dia COVID-19 positif, tapi tetap saja dilanjutkan dengan syarat tetap menjaga kebersihan ya, tetap cuci tangan, terus menggunakan masker dan sebagainya, karena memang potensi untuk tertularnya bayi itu hanya dari kontak ke ibunya, mungkin dari bersin dan sebagainya. Kurang lebih itu ya tadi yang disampaikan oleh Michelle. And another question for
itu ada semacam modul dari WHO, apa yang dikatakan oleh Michelle betul. Jadi bukan lewat darah, bukan lewat ketuban, bukan ASI, tapi ini loh, nafas. Jadi kalau mau menyusui, ibunya yang harus melindungi diri itu. Jadi selama ibunya masih melindungi diri lubang hidung dan mulutnya ini dan tangannya, itu anaknya aman gitu. Jadi ibunya yang harus itu, kan. Dan pengunjung jangan lupa melindungi ibunya, tapi neneknya cium-cium dia bayi sama saja kan gitu. Jadi anak harus dilindungi dari pengunjung. Yeah, Louis and Michelle, I talked to Mirgi and all friends. There is the WHO guideline how to keep breastfeeding to the baby, even the mother getting COVID-19 positive. Yeah, no prohibition to giving the breastfeeding, but the mother should take care how to cover the mouth, how to cover the nose, and the move of the hand to keep transfer the virus to the baby. Also, prevent from the grandma or another neighbor to come to kiss the baby. Please prevent that. Yeah, this is to be the infection resources. Okay, thank you.
Yeah. Thank you, Dr. Sutrisno. I mean, this is very interesting. Sometimes we only focus on the mother, especially in Indonesia, because many people will come to visit the baby, right? So yeah, we have to be aware as well. All right, thank you. And another question for Michelle: how to educate pregnant women to continue doing antenatal visit, even though during the COVID-19 pandemic, because we cannot deny that we have to do this social distancing. Also, maybe the women are not, are afraid to visit the health care providers.
Yes, I think it's the communication is very important, that we are communicating directly with communities, that it is safe to come to the health facility, and that there are specific measures taken to reduce their risk when they come to the facility. So if women have a fear of getting COVID by coming to a facility, the best way to help them is to reduce their fear and increase their confidence that it's safe and that they can take specific actions to reduce their risk: social distancing, keeping their hands clean, wearing a mask, but that the health and well-being of themselves and of the baby means that coming for antenatal care is really important, and that their risk of COVID is less than their risk of having a pregnancy complication.
Okay, thank you, Michelle. And Now I have some question for Dr. Sutrisno. One of the audience has an experience that she met a normal, straightforward pregnant woman, but she was COVID-19 positive. During the labor, she suddenly suffered a seizure. I mean, maybe it was eclampsia, right? During delivery. So what should midwife do? I mean, if they meet this kind of case?
Itu persalinannya di mana, Mbak?
I don't know. Tidak menyampaikan. Jadi semua hasil pemeriksaannya itu semuanya normal. Cuman ibunya positif, tiba-tiba kejang aja gitu. Apakah itu ada dampak dari COVID-19-nya?
Sebenarnya tidak. Artinya kalau memang COVID-19 itu penyakit 1000 wajah. Kalau mengenai saraf ya kejang turun, kalau mengenai jantung ya langsung gagal jantung, myokarditis, mengenai nafas ya terjadi pneumonia, depresi nafas, mengenai darah ya koagulasi, emboli luar biasa, jadi endotelitis, jadi 1000 wajah. Cuman memang kalau seorang wanita hamil, persalinan, kejang, tidak ada tanda-tanda klinisnya COVID, mungkin lebih dekat ke eklamsinya, ya, eklamsinya. Itulah pentingnya early warning system. Jadi teman-teman bidan harus belajar tentang early warning system, apakah ini layak ditolong atau tidak di tempat Anda gitu. Jadi nanti baca ya, early warning system itu ada berbagai macam variabel gitu. Nanti ada skornya. Kalau skor sekian, ya nggak layak saya tolong gitu. Jadi harus saya refer gitu ya. Itu memang itu pentingnya early warning system ya. Terus yang kedua rapid test. Nanti rapid itu ya ada sedia atau enggak itu ya. Memang susah saat ini. Terus yang ketiga, kalau Anda memang kejang, pasien kejang jangan kupu. Artinya pasien kejang jangan langsung disuntik SM. Nanti telah tambah tidak bisa nafas ya. Ya kejang tunggu saja, selamatkan supaya dia tidak fraktur, tidak tergigit, tidak jatuh, tidak patah ya. Setelah kejang itulah baru ditolong ya, dikasih oksigen. Kalau memang tensinya tinggi ya dikasih SM, tapi setelah baik dulu, bukan saat kejang, ya kan? Dan tentu kalau memang skala 2 persalinan ya selesaikan persalinannya dan jangan lupa diberi infus dan siap-siap untuk rujuk. Jadi kalau sudah semacam itu meskipun beres ya jangan lupa rujuk karena memang cerita Anda itu tidak lengkap ceritanya, tetapi saya lihat gradasinya itu kok berat gitu ya. Persalinan, kejang, positif lagi ya, jadi berat. Jadi saya sarankan kalau memang ibu hamil positif, ya sebaiknya tidak usah ditolong oleh ibu bidan. Ya, jadi begitu tahu dia positif swab ya tolong kirim. Tapi kalau positif rapid tolong konsulkan SPOG, ya kan? SPOG ya. When you are getting the pregnant mother with a positive swab, positive PCR, please refer to the hospital. When the mother getting positive in rapid test, please consult to OBGYN specialist. The OBGYN specialist will make decision what kind of delivery mode that's suitable with just pregnant woman. Yeah. For normal labor or should be cesarean section. The decision should come from the OBGYN specialist. Yeah. If the OBGYN specialist mentioned you can getting normal labor, please the midwife do the normal labor. But if the OBGYN mentioned not good for normal delivery, please cesarean section will be done by OBGYN. So I hope all the midwives take care in the early warning system how to detect the COVID-19 in early phase. Yeah, because this virus is very difficult. The virus is 1,000 phases. The virus look everything in clinical setting. So no specific sign and symptom that typical for COVID-19. Yeah, it can looks and appears like everything. We are the doctors also face the puzzle every day when we face the COVID-19 patient. So this is very difficult thing. Okay, thank you very much.
Okay, thank you. And you have still another question.
Yeah, yeah. I think that I'm agree with Dr. Sutrisno. That why in the principle of midwifery care in this pandemic COVID situation, that we have the pre services first, that they have to be registered based online. In this registration, they can communicate, they can assessment, they can fulfill, they can collect all information. If there are some information or maybe one information indicate that they are suspect or whatever, we have the early warning system. And I'm sure that I asked my colleagues, my lovely colleagues, you must not take a risk. You must not take a risk to ask this patient to come to your clinic. If you find it, you directly refer, even though to public health center or maybe to the hospital. I think you must not take a risk. Okay, Dr. Sutrisno inform how many doctors, also midwife, some midwife, they are also died by COVID. And be careful. We have to comply to all standards, to all regulation, what we are developed together, what we share, and also my colleagues, I think the how to increase the awareness of these COVID viruses. Thank you.
Okay, thank you. I mean, it's a very strong, statement from Bu Emi that don't take a risk if you've met high-risk pregnant women, because we have to remind that midwife should, help normal, straightforward pregnant women, right? Okay, thank you, Bu Emi. And I still have one question for Dr. Sutrisno. Is breast milk production influenced by COVID-19 if the mother is COVID-19 positive?
Ya. Kita bermain data. Jadi WHO itu selalu mengatakan based on scientific report. Jadi tidak pernah menceritakan suatu alur yang disusun atas dasar temuan ilmu penelitian, tapi based on scientific report. Jadi hanya kumpulan-kumpulan data, itu WHO katakan sekarang. Kenapa? Karena ini masih baru. Di laporan mengatakan puluhan sampai ratusan laporan ilmiah mengatakan bahwa tidak ditemukan bukti yang cukup bahwa ada virus melewati ASI. Tidak ada yang bukti yang cukup. Kan? Tetapi pernah dilaporkan ada fragmen RNA yang ada di ASI. Ya, ada fragmen RNA yang ada di ASI. Tetapi fragmen ini bukan virus secara utuh. Ya kan? Artinya dikatakan bahwa fragmen yang ada di ASI itu bukan fungsional. Artinya tidak cukup bukti bahwa itu akan menyebabkan infeksi. Sehingga itulah kenapa bahwa breastfeeding masih direkomendasikan. Ya, masih direkomendasikan dengan justru ibunya yang harus menutup lubangnya, karena memang lubang hidung, mulut ini dan tangan adalah sumber transmisinya. Ya. Jadi based on the data, based on the scientific report, maybe 100 scientific report, no proof that there is RNA material inside the breastfeeding milk. That's why WHO still recommend in giving the breastfeeding to a baby. Yeah. But with specific care, mother should take care to cover mouth, to cover nose, and also to prevent the hand, to keep always clean, prevent the transmission from the respiratory of the mother to the baby. So I mentioned to you an emphasizing point that breastfeeding still now scientifically proved safe. Yeah. Thank you.
Okay, thank you, Dr. Sutrisno, for the explanation. I mean, it's clear. So now I'm moving to the question from Deb. This is the question is about postpartum mothers. So the mothers are afraid to visit their midwife during the pandemic. So the audience has had a client who experienced because of the lactation problem. So what should we do to maintain the psychologies of mother after the labor during the COVID-19? Yeah.
Yeah. So what typically happens here in Australia is that women are undertaking their antenatal care. They have the Edinburgh postnatal depression scale, which they routinely complete. And then on the basis of that, the women are provided with the support that they need going forward. My sense of it is that in this particular instance, obviously it's really important to have support for this, for women in this particular situation. You know, to the extent that the support can be delivered online, that might be something that could be considered. There's really good research evidence that providing online support can often be as effective as providing it face-to-face. You just have to be, I guess, a little bit alert to the fact that it can be more difficult to read signs and symptoms when you're having a conversation online rather than face-to-face. But that might be one thing. The other thing too is that you know, you might consider routinely providing women with information before they leave the hospital about who they can reach out to. And certainly there, at least in Australia, there are a lot of online resources that are available. And I've provided them in the past to Mergy. And I can definitely, you know, provide those resources again. In the possibility of perhaps some of the basic resources being translated into Bahasa so they could be routinely distributed.
Yeah. Do you mean MMPI, right?
Sorry, Mergy?
Do you mean MMPI instruments?
The Edinburgh postnatal depression.
Yeah, I think it's Edinburgh is also familiar in Indonesia, I guess. Yeah, so maybe there are many translation document for that.
Yeah, I think there is one into Bahasa. Yeah.
Yeah.
But in this case, I think, yeah, as much as possible, providing online support would be a good idea. Louise, what do you do in the UK?
We are offering online support, and that's both by well, we can do it video call, but also if women want to do that over the telephone. But it is a really important time that women know that they can speak to their midwives, and I think it's, as a midwife, we just need to make sure that women feel comfortable in using those kinds of forums to communicate through. But it is quite a challenge, and I think dependent on your level of lockdown, then it can be also a challenge, because it could mean isolation, you know, not being able to for the rest of the family come see the baby. Those have been issues that we've had in the UK in the early strict lockdown we had in at the end of March and April. So I think it is just making sure that women know that they can talk and people are going to be there to listen.
Yeah, I also think that it can sometimes be quite important when women can hear from their midwife that the feelings and the thoughts that they're having are, you know, understandable at this time, that, you know, it's quite reasonable and appropriate for them to have these concerns. I think there's something quite powerful in having someone like your midwife kind of normalize your feelings, because when you do that, it's kind of inviting the woman to open up to you, and it's reinforcing and reassuring her that, you know, she's actually being very reasonable in having those thoughts. Louise, what do you think about that?
No, I agree, Deborah. I think you know, to be able to be honest, and also in some respects that empathy of saying, I know exactly how you feel, you know, that this is a time, and making it in that respect that they're not alone. It's not only them feeling like this, that it is a normal behavior given the circumstances everybody's in, and then that hopefully will make women be able to say, yes, that is how I feel. I do feel isolated. I do feel like I can't speak to anybody. And then you can start those conversations and direct women to where the support is.
Yes, and I think adding to that, it's really important to first seek to understand rather than jumping in with advice. First, listen deeply to the woman's concerns, and then try to tailor your information and your advice based on her individual circumstances.
Oke, ya, berarti tetap tadi sarannya online ya kalau bisa, dan memang sama-sama efektif, meskipun online sama aja efektifnya dengan ketika bertemu gitu. Kemudian tadi ada saran dari Prof. Deb juga menggunakan Edinburgh Scale tadi, mungkin bisa dicari. Saya kemarin juga beliau sudah menjelaskan, banyak sekali sudah yang ditranslate gitu ke Indonesia gitu ya. Okay, one question for Deb is, if postpartum mothers are still under COVID-19 treatment, is there any evidence showing that whether it has an effect to breastfeeding? I think we have answered this question, right?
Yes.
Yeah. Okay, it's from Yanti. Okay, Bu Yanti. Yeah. Okay, I think we have answered the question before. And the last, the question for Bu Amy. So what is the effective strategy that we can do right now for maternal health services in Indonesia? Because I mean, Indonesia is quite different with Australia and other settings.
I mentioned in my presentation, we have to give the opportunity to our women, to pregnant women, to when they are looking for the antenatal care, let's say. That's why the strategy, how is the strategy that we have to follow the standard, and we have to use the early warning system, and also we have to communicate. The communication is very important here. Before they come to our clinics, we have to communicate first, because Deborah and also Lois, here in Indonesia, we have so many persons without symptom. They are going anywhere, do anything. That's why our midwife, we have to prepare we have to get the information comprehensively, specifically for the new pregnant woman. They come from the zone or the red zone or whatever. Sometimes, honestly, that I would like to say, they are not open for the information. Sometimes. I think it is also that why I invite my colleagues, please be careful, please use the strategic. We divide it in 3 terms of services now, before they come, during we give services, and after for the follow-up. In previous, no, we don't have this strategy. This is the strategy. I think that this strategy, when you are using, when you are implement this strategy, we hope if you identify one pregnant woman, they have part of the indication, you don't ask them to come to your clinic. That once again, you must not take a risk and you directly refer. I think this is the strategic why we divide it in 3 kind of services now. Really different with the previous. In the previous, you know, Lois and Deborah, in midwife clinics, in the midwife independent clinic, you know, I didn't present the data. Almost 70% maternal and child health and family planning included served by midwife.
Right.
Almost 70 to 75%. Let's say 82% antenatal care done by midwife.
Yeah.
62% delivery done by midwife. Normal delivery, of course, Dr. Sutrisno, normal delivery. And also 75% family planning done by midwife. That's why so many people, they trust, they come, because in the previous situation, they have no problem with the timing. The midwife, they open their clinic daily, but not now. You have to manage the time. When you prepare, when you all ready to serve the pregnant woman, they come. But when you are not ready yet, that's why you have time when you are communicate first. You can prepare, you can, everything you need, you can prepare before you receive a patient in your clinic. You can see in the innovation, there are so many patients in midwife clinic. They can come together. In the previous picture, in the last slide, my last slide, you can see there are many patients come in the same time to the midwife clinic in the previous, but not allowed now. Not allowed now. To protect you and also to protect them. Okay, Mbak Mergi?
Okay, thank you very much, Bu Emi. I think it's a very, again, strong statement from Bu Emi. And I think we are now all the question, no, not all the question, but this is the end of the Q&A session. But I can conclude that, yes, COVID-19 remains the challenge for every country, including Indonesia, especially in maternal health.
Maybe I have one question to Lois.
Okay.
Can I?
Yes, please, Bu Emi.
That in the UK, that you have a limited number of staff. I know also shortage midwife there. How to take a solution for this this time, Alois?
Okay, well, one of the solutions that happened very quickly, and this was within nursing, midwifery and medicine, is that there was a call out for people who were actually not actively practicing, who could come back and join an emergency register in order to support the workforce. So that happened and was actually mobilized very quickly. The other things that we did was we deployed senior students, and it was because our students, obviously with university students, they don't get paid, but they were actually paid to go and work as part of the workforce, not as qualified midwives, clearly, because they weren't qualified, but in a capacity where they could support midwifery. So that actually boosted the workforce and took us through that period when the uncertainty of people getting ill and having to self-isolate because of symptoms. But also in the UK, we've had a number of health professionals, doctors and midwives and nurses who have unfortunately died from COVID whilst they've been working. So, you know, that again, it's a worldwide thing of us losing our own whilst we've been caring for women.
Okay. In the emergency situation, there are some exception we can do it. Yeah.
Yes. Yeah.
No license, but we can organize them. I think. Thank you.
Thank you.
All right. Thank you. It's a very interesting question. And then thank you very much for all presenters for their informative and interesting talk. Very well, ladies and gentlemen. Before finally we come to the end of our seminar today, we would like to say thank you very much for all the speakers for their informative and interesting talk, and to the audience for your active participation. We hope that the presentation will be beneficial for everybody and maternal health in Indonesia particularly. Thank you for your attention. Stay healthy. Good afternoon.
Thank you very much.
Thank you so much.
Thank you, Ibu Debra. Thank you, Ibu Lois.
Terima kasih.
Thank you.
Very nice to see you again.
Thank you, Louis,
Thank
Deb,
you.
myself. Thank you.
Thank
Thank you,
you,
Mercy.
everyone.
Thank you, Maggie.
Mohon maaf, mungkin saya tutup dulu ya,
Ya.
Dokter. Bu Emi, saya tutup dulu. Oke, saya akan kembalikan kepada terima kasih Mergi buat telah memandu acara ini dengan baik. Dan baik, kita akhirnya kita masuk ke bagian akhir dari acara ini. Terima kasih untuk semua para pemateri. Thank you for the insight, Prof. Deborah, Prof. Louis, Michelle, dan Dr. Tris. Bu Emi, terima kasih. Dan terima kasih buat rekan-rekan seluruhnya dari AIPKIN, kemudian masih ada Bu Loren juga di sini, dan seluruh pimpinan di Prodi jurusan. Dr. Bar juga masih di sini, teman-teman juga masih ada di ruangan ini. Tentunya terima kasih untuk semua yang hadir, baik ada di Zoom meeting ini maupun di YouTube. Dan mengulang informasi yang telah saya sampaikan di pembukaan tadi, bahwa e-sertifikat akan terkirim melalui email masing-masing, dan tentunya sesuai dengan email yang sudah dituliskan di link absensi dan juga evaluasi. Para hadirin sekalian, kita telah sampai ke bagian akhir webinar ini, mewakili seluruh panitia dan penyelenggara dan jurusan kebidanan Fakultas Kedokteran Universitas Brawijaya, mengucapkan banyak terima kasih atas perhatiannya, dan kami mohon maaf jika dalam penyelesaian webinar kali ini banyak sekali kekurangan. Dan dengan demikian berakhirlah acara webinar kali ini. Sekali lagi terima kasih yang tak terhingga buat para seluruh pemateri dan juga para panitia untuk acara webinar hari ini. Saya tutup dengan wassalamualaikum warahmatullahi wabarakatuh. Selamat sore dan salam sehat untuk kita semua. Terima kasih.
Terima kasih Bu Emi. Thank you, Michelle, Louis, Deb.
Terima kasih.
Terima kasih.
See you.
Bye. Bu Yeti, Bu Yum, terima kasih, dan juga teman-teman yang dari UNAN.
Masih ada Bu Yumi ya?
Ya masih ada Bu, masih hadir.
Masih hadir. Oke.
Ada Bu Wati, terima kasih Yosefa dan terima kasih.
Oke Bu Laren, terima kasih buat kehadirannya.
Ya, terima kasih banyak. Salam Bu Wati.
Ya Bu, salam Bu.
Saya izin live.
I'm going. Bye bye. Okay, thank
Terima kasih Bu.
Bye, Smea.
Ya, terima kasih semuanya.
Terima kasih. Terima kasih Bu Emi.
Ya. Bye.
Oke.
Terima kasih Bu Eva.
Pak tunggu, saya juga live dulu ya.